Good morning. Today we have Professor Sudhir Kumar with us to talk about shoulder history taking and examination. Good morning, sir.
Good morning. Shoulder is a joint which is in fact made of four composite joints, including the glenohumeral joint, scapulothoracic joint, acromoclavicular joint, and sternoclavicular joint. All these joints come into play while the shoulder problems arise. In fact, the elevation of arm in most of the activity is required, and the initial 20 to 30 degree of elevation is purely done by glenohumeral joint, while beyond 30 degree onwards up to 120 degree, the glenohumeral and scapulothoracic jointly move the joint to elevation in a ratio of 2:1. So for every 20 degree of glenohumeral movement, beyond 30 degree of movement, 10 degree of scapulothoracic movement take place right up to 120 degree. Beyond 120 degree, elevation up to 180 degree is mostly done by the scapulothoracic movement. In the absence of glenohumeral movements, that is when the glenohumeral joint is fused, then the scapulothoracic movement elevate the arm right up to 60 to 65 degree by a shrugging mechanism. Shoulder is many a times presented with the history of trauma in younger people. So a history of trauma is an important historical event which need to be ascertained with these patients presenting with pain in the shoulder joint. The onset of the problem of the pain in the shoulder could be in acute form or at times being occurring for a chronic presentation. So in acute form, it could be because of any infective pathology where you may have the history of constitutional symptoms, which the patient would be able to tell you that he had a fever, he had a loss of weight, he has a loss of appetite, and while in chronic situation, there could be a pain seen in the elderly people or the middle-aged group where they may tell you a grumbling pain occurring over a period of time in particular activities or pain at night. So it is important to elicit the onset of these problems in the shoulder very emphatically with these patients. The type of pain could be a very grumbling pain which could be in certain movements of the joint, or there could be a excruciating pain which one may get immediately after an injury. So while the injury occurs on the shoulder, this could be a sports injury which you need to elicit that while playing he has used the shoulder in a manner in which it has given it a acute pain, or a repeated activities of particular movements of the shoulder may give rise to pain. Hence, the pain could also be seen in the patients who have who could tell you that the pain might be coming from the neck, or from the chest, or from the areas beyond these neck and chest, like right from the abdomen, particularly on the right shoulder. So they are known as referred pain. So these referred pain need to be excluded out from these patients. And also, is the pain of the shoulder being referred to the upper limb, right up to the hand or to the elbow, also indicates that the patient might be having a problem right in the neck. So hence, while asking the history from a patient with a pain in the shoulder, which is the most important presenting feature in this problem of shoulder, the patient may also tell you certain disabilities which are noted while performing certain activities. So he may tell us that while sleeping in the night, he gets pain while taking sides on that side, and this may also indicate that he might be having an impingement onto the shoulder. Or at times, we have patients who come to you with a sudden rupture of the rotator cuff, in which they may just tell us about giving way of the shoulder or inability to lift the shoulder in a particular direction. To initiate shoulder movement in a particular direction may indicate that the patient might be having one or the other rupture. So hence, the history of trauma and a history of pain is of an important feature in the patient presenting with the problems of shoulder. While examining the patient, such patients, we need to look at their general body habitus. What is the physical buildup of a patient is important. And in such patients where you may have a poor posture, which may be because of fatigue of the muscles around the shoulder, that indicates that is your patient suffering from any muscular condition like myasthenia gravis, which is also important while examining these patients. While examining these patients, we should be able to find out the patient is not having a pain referred from cervical spine, from the chest, or the subdiaphragmatic region, which need to be excluded out in the examination. Hence, the examination of cervical spine is of great importance before we proceed to look at the shoulder in particular.
So local examination.
So in the local examination, we start right from in front. Look at the contour of the shoulder to detect any atrophy. Because in reflex sympathetic dystrophy, you might find a swelling, a shiny skin, or there could be decrease or increased sweating in the palm, and the patient may not be keeping his arms by the side of the body, or he might be holding the arm in the other with the support of the other arm. In patients where you have atrophy of the shoulder, the contour of the shoulder will be lost, and you may find absolute flattening in the outer border of the shoulder. Just we emphasize that these patients should be completely undressed right in the upper part of the body so that the look can be very emphatically seen from front, from behind, and from side. So undressing the patient to visualize head, neck, both shoulder, upper limb and trunk is important. The muscle wasting in the deltoid region